So we are here to, in the next 25 minutes, solve for the future of Medicare. So we should have some fun. I wanted to start this conversation with you all by talking about the trustees report. I want to ask each of you, starting with Tara, and we'll come on down the line, what was your most important takeaway from that trustees report, and what do you think we should be focusing on talking about the future of Medicare and the cost curve?
Yeah, so I think the most important thing is probably also the thing that it's like, yeah, okay, we've heard this before. The trust fund will be depleted in 2026. And it's one of those things that you've heard it so many times now that nobody really cares. But I think that's why it matters so much, because we are getting closer and closer to that date. It's not changing. And so, it really should be raising alarm bells, and it frightens me that it's not. So I think we need to be focusing on doing something. We need to take action, whatever it is. That date is getting closer and closer. And every year that we put it off, it gets more challenging to actually do something, which makes us run away from it. And it's kind of this terrible cycle.
I couldn't agree more with her. I mean, we need to do something, and there's hard choices to be had, right? We can do something on the expense side, or we can do something on the revenue side, and neither are very politically popular decisions to make. But with a 2026 being right in front of us, we need to at least take some steps in that direction, whether it's around what we do with respect to prescription drug costs, how we try and make sure that the Medicare Advantage program sort of continues to become more of a standard within the Medicare program. If we look at the spending in Medicare Advantage beneficiaries on a per capita basis, it's only increasing about 1% per year over the past 9 years, right, versus overall trends. So I think there's a number of steps we could take, but we can't just sit around and wait.
Yeah.
The time I have, I want to focus on the other parts of the trustees report, parts B and D rather than A. The reason is because part A will get resolved by 2026 or before, because it has to be by law. The trust fund can't pay out if they're not assets there behind it. Whenever we get into this situation, and it's happened several times in the last 2 decades, it becomes an event forcing mechanism, either to find additional revenue, another revenue source, or increasing the tax rate, or by moving, which was one of our past tricks, moving some of the Part A spending into Part B. The part I wanted to focus on is why we ought to be really concerned about Part B, the part that pays for physicians and labs, and Part D, the outpatient prescription drug. And it's because it doesn't have an automatic forcing mechanism. It is paid for by a combination of premiums and general revenue. And it's the increase in the general revenue drag that concerns me. And finally, the issue that needs attention is the total spending. Again, Part A is an event forcing mechanism. We will do something to change that. But the growth in Medicare, in part because of the doubling of the population that's on Medicare, and because per capita spending has been growing as well, means that in 2040, we'll almost double the share of the GDP that we spend on Medicare relative to what we spend now. Of course, we can do that. But it will put fiscal pressures in place that people may not be prepared to think about what it will mean, either in terms of less spending elsewhere or more taxes going to Medicare, or some combination.
And building on what Gail said, an action forcing event, I think something for all of us in this room to think about is that when you're faced with a deadline like 2026 and Congress comes in to fix it, you're looking at across the board cuts. You're looking at really budget tools to fix a healthcare problem. And for me, that's really concerning, because you're not getting at value. You're not looking at outcomes. You're not looking at patient affordability. You're just looking at hitting a budget number. And I think for me, that's really scary. And I think for all of us, it should be scary, because 2026 is coming up. And if there's not action before then, I think all of us and the things that we care about in the program could be at risk.
Gail, you led Medicare and Medicaid under George H.W. Bush.
Right.
And you talked about in your answer sort of the semi-regular cycle of panic around the trust fund. What, in your experience, in your perspective, has this regular pressure done to policy? And are there opportunities, you think, in this round to meaningfully change the way we respond to and think about the long-term solvency of Medicare?
It's hard for me to share how frustrated I am that we are in the position we're in, because it was completely predictable when I was running the program in the early 1990s, what would happen as the baby boomers started to age and the smaller cohort of workers were funding the program. And yet, then the next decade, the decade after that, starting 2010, when the baby boomers were first starting to enter into retirement officially, January 2011, we have done nothing. The reason it's so frustrating is that the easier solutions would have allowed for a gradual transition to either different kind of spending or coverage or funding, like we did with the Greenspan Commission in terms of changing the retirement age by 2 years over a 25-year period. But we've taken away any ability to have a gradual slide into something new by postponing what we're doing. We need to think about the kind of program that makes sense for the next couple of generations and putting that in place. But at the same time, we're going to have a lot of pressure because of some of the immediacy of the funding challenges. We can still do a variety of things to change that. We just can't do them as gently as we might have been able to. And that's a shame on us, all of us collectively, because it was just completely predictable. Everybody who's on Medicare or going on Medicare now had been born way before I was running the program in the early 1990s. So it's not like this is a surprise or a mystery where we are now.
Matt and Tara, I want to ask you all, we're thinking about the political ramifications of this report, and Medicare is always a political issue when we have presidential elections. What are the things before that election that industry leaders and perhaps people in Congress, if they ever agree on one thing, can do to perhaps give the program a little bit more life?
Yeah, sure. So I want to first just comment on what Gail said about Parts B and D. Those programs, are drawing from general revenues and largely are funded by debt. And since the program was created, Medicare has contributed $5.1 trillion to our national debt. It accounts for 33% of the federal debt. And so it really is a significant fiscal problem for our country. So we do need to be working on this issue. I think right now we're seeing the policy conversation is really focused on drug pricing, and not to say that that's not an issue where there are problems that need to be resolved, but it's such a small piece of the pie. The majority of funding is in Part A and Part B, hospital and physician services, and we're not really doing anything there to address those costs. And so that, I think, is something that we need to also be focusing on. Of course, you can only do so much. There's only so much attention, right? So maybe if we can make some progress on the drug space, we need to quickly move on then to prices in the hospital space, et cetera. And some of those issues that are forcing consolidation, which the irony, I think part of the consolidation in the hospital space that's driving up prices is this drive towards ACOs. And so that's something that we're trying to do to save money, but yet it's driving consolidation and then prices go up. And so it's really countering the goal that we're trying to achieve there.
I just wanted to add one nuance, and that is what we're focusing on now is actually not just prescription drugs, it's Part B. Because Part D, with its competitive plan structure, seems to be doing quite fine. The real shame here is that we did B first, because if we hadn't done B first, B would be part of Part D. In the private sector for the under 65 populations, they don't use separate contracts for specialty drugs versus the rest of outpatient drugs. It would have been so much easier to handle if we had done it in that order, but the historical timing of the adoption precluded that from happening.
Well, and we're looking at Part D, but patient affordability is a real issue too. I mean, it's one of the very few programs, the last program without a cap on out-of-pocket spending, and that's something like the debate hasn't focused, I think, on that issue as much. I know the American Action Forum is looking at some ideas, and we're supportive of that, and that ought to be on the table as well, for sure, as we're looking down this road.
So I'll jump in, and I think the provider consolidation and hospital prices is a big problem. I think some of the policies that we're pursuing in the short run, particularly on the prescription drug side, are very problematic and troubling. The proposed rebate rule that the administration is moving forward with would increase federal spending, right, by all estimates by about $200 billion based on OAC's estimates, based on CBO's estimate, 177 billion, so maybe not quite 200, but we would love to see things like an out-of-pocket cap in the Part D program, but how are you going to pay for it? If you had a way to spend $200 billion, would you really do it on the rebate rule, or would you look at things like an out-of-pocket limit that would help the entire Medicare beneficiary population versus what we're proposing? That's really only going to help a very small subset. So there are a couple of things I know that we would focus on in the short run.
Liz, I know you have.
Go ahead, Liz.
And I know you're going to get to this in the next panel in your conversation with Steve Ubel, but the rebate rule, first of all, if you're just looking at that one number, the estimates didn't take into account any behavioral changes. So it's a point in time. I also think you ought to consider that right now, premiums have been held artificially low because people are paying out-of-pocket costs that are just unaffordable. And so I think what the rebate rule is trying to do is sort of rebalance that equation. And I think if you look at the increase in federal spending, I think it depends on how you look at it. If you look at all of the estimates and you take into consideration some of the behavioral offsets, there could actually be potential savings, not spending. So like everything in healthcare, it's complicated, but I would encourage people to look at the big picture and not just the one number and use that as the talking point.
Yeah, and I would actually like to jump in on that as well. I think there is a potential for increased spending, and that certainly is troubling to many people as we're sitting here talking about the fiscal problems with Medicare, right? And so anything that could increase spending $200 billion, that's frightening, and I think the instinct is to run away from it. And also, mathematically, we know that the majority of seniors are going to see their premiums, well, every senior will see their premium rise, and most of them will not have that offset by reduced out-of-pocket costs. And so, yeah, most people will probably be technically worse off under this, but from a policy perspective, from an insurance policy perspective, what insurance is supposed to do, I think this is absolutely the right move. Right now, you have the people who are sick taking these expensive drugs, subsidizing the healthy. They're subsidizing everyone, and that's the opposite of what insurance is supposed to be. And again, with the behavioral changes, we don't know what's going to happen. I personally believe that pharma is kind of on the hook. They've been campaigning and saying, we need to share the rebates that would bring down the out-of-pocket costs. And so if they don't then come through and continue to provide the value of those rebates in these discounts, then they no longer have, an ability to point the finger. It's then definitely on them.
I'd say the challenge, no one has said that they're going to lower their prices though, right? And it starts with the price, all right? I mean, manufacturers set the list price, no one else. They make decisions about when to increase price, no one else. They could voluntarily make decisions to decrease prices. And we haven't seen any of that behavior yet.
I do want to talk about the behavioral stuff because we talked backstage about also leveraging the social determinants of health and thinking about ways we can perhaps, without getting past some of the thornier issues with drug rebates and drug pricing, lower spending. And so how are we thinking about the social determinants of health, the greater challenge of this demographic and healthcare problem that's really what the Trust Fund report shows?
I'll jump in. I think I know a lot of our Medicare Advantage members are very focused on social determinants of health. Our entire membership is recognizing the connection between sort of where you live, what you eat, what opportunities you have to get to the physician because of transportation, and what your health outcome is. And I'd say the administration has done a really good job in terms of trying to provide much greater flexibility with respect to social determinants in the Medicare Advantage program. Medicare Advantage plans now have much greater flexibility to provide in-home services, to provide transportation, nutrition, adult daycare, all of these things that we know will have an important impact on health, and I expect that to grow over time.
It's true, but they're only playing around the edges with
True.
regard to Medicare Advantage, because you need to provide the medical services, and then to the extent you can carve out some additional spending to go after the social determinants, you can do it. If we're serious about looking at the social determinants of spending, and we should be, this is mainly an under 65 issue that you need to focus on. You really want to focus on people when they're growing up, when they're born, when they're growing up, going to school, the kind of training they get, ways to keep them gainfully employed in the workforce, able to transition as the economy changes over time. We spend a ratio that is inverse to what every place else in the country does. If you look at the spending on the social determinants versus medical care, we do 2 to 1 in terms of the spend on medical care versus social determinants. Most of the rest of the world does 1 to 2. But this is, while it would make life nicer for the seniors if we could have a little more shifting going on, when I hear discussions about the social determinants, it's, if you're serious, you really want to hit people from birth through the time that they're going into old age. That would have much more impact on what happens as a senior than anything else I can imagine.
I think that's true, but there is a role for the incentives to increase value in our system and pay for outcomes and align the payment incentives. So I think we can't ignore that there are incentives. We could do a better job of trying to drive better outcomes, and I think we're at the cusp of doing that. You're right, we don't have all the answers, but that ought to be part of the solution. And again, if we're just looking at the budget and we come up with a budget approach to solve these problems, we're going to miss out on trying to really increase the value and quality of care that I think will get to some of those social determinants issues.
Now, I have a follow-up, but I do want to let you all know we're going to open the floor up for questions in just a moment. So please get ready. We're going to have a mic going around the room for questions. And the last one I have is for Liz. It's we just got the finalized ruling from HHS this morning that they're going to pursue requiring pharma companies who make direct-to-consumer advertisements to put the list price on those advertisements. What is, from Johnson & Johnson's perspective, what is your perspective on that ruling, and how do you think it will affect the industry?
Well, first of all, let me say I'm proud that Johnson & Johnson has added and committed to adding list prices to DTC ads, but also along with information about out-of-pocket cost sharing and what patients would actually pay out of pocket. I also want to point to the industry's efforts. So pharma has just launched a website that will provide the same information for ads that are on TV. You can go to the website. I think I'm looking at someone, mat.org. If you want to look for that information, I think it's out there, and the industry is looking at ways of doing that voluntarily. You know, for me, the question is, there's one thing about us doing it voluntarily. There's another aspect to this when the government tells you have to. We haven't had a chance to look at the rule to see whether what we're doing actually complies, but I think as a company that's been trying to be forward-leaning, we'd like to think that there's enough flexibility that would allow us to continue to do what we're doing and allow solutions like what pharma has proposed. So we'll see. We haven't looked at the rule yet, but I'm sure your next panel will get into that as well.
I believe we will. All right, now I do want to open the floor for questions. So we have one right here in the back.
Hi, Arlene Bierman from the Agency for Healthcare Research and Quality. And I want to follow up on Mr. Rother's question before on multiple chronic conditions. 80% of Medicare beneficiaries have multiple chronic conditions. They disproportionately account for the high costs of Medicare. And as well, they are subject to duplicative care that's expensive, as well as expensive adverse outcomes from fragmented care. So my question for the panel is, what do you see as the role of health services research in developing the evidence for the most effective and efficient models of care for complex patients?
No, I mean, having started my career in Washington there, I think what the agency can do to be helpful is to be specific about the kinds of changes that would be most impactful for the delivery of chronic care and the treatment of chronic care for people who are on the Medicare program, who by definition are seniors. Looking at care outcomes as being much more than the treatment of medical care per se, and particularly when you're treating chronic care conditions, I think will give us an opportunity to have better outcomes. It really points to why it's so important that the Medicare Advantage program has been developing as rapidly as it has. It's very hard, not impossible, but it's really hard in traditional Medicare because it's so stovepiped. You have Part A that's focusing on the hospitals and nursing home, and Part B that's focusing on the doctors and labs, and then Part D on outpatient prescription drugs. But so much of the treatment of chronic care involves blending the best blend of all of those services, and it's just hard to do in traditional Medicare. It's not impossible if you have an active coordinator, it's just much harder. So I'm hopeful that the growth of Medicare Advantage, when done well, it's not always done well, will allow for the treatment of chronic care, which is just a dominant part of the delivery system.
I'll just add on, and I agree with Gail on that perspective. I mean, we have sort of systematically underinvested in health services research over the past decade or two, knowing that if we were able to figure out what really worked most effectively, that could have a very beneficial impact. I am encouraged both by the activities of Medicare Advantage plans and the role that data and analytics can play today in terms of really identifying how we should best address people with chronic conditions and the comorbidities and the correlations between different conditions and how you can intervene. And I think that's a growing area of promise. I think that we'll see changes down the road as we are able to leverage sort of new data analytics technology to really make a difference with chronic conditions.
We have one more right here.
Julie Kandra-Weinberg with Prime Therapeutics. We're a PBM owned by 18 Blue Cross Blue Shield plans. In the discussion of the rebate rule, nobody mentioned the 12% of Part D eligible beneficiaries that don't sign up for coverage and have no other coverage. So two different questions. One, what you thought the rule would do for those 12% and how we can incent people to sign up for the program. And second, and this pivots right off Gail's comment, will we ever get to a place where we don't have 4 parts of Medicare and instead we have an integrated benefit? Thank you.
So I want to actually maybe try to answer that question and also respond to something that Matt said earlier, that nothing is going to happen to list prices. I actually don't think that's true. If you look back at the Senate Finance Committee, where a lot of the pharmaceutical leadership testified in, including our global head of pharmaceuticals, we have said that the list prices will come down if the system becomes more fair and the rebate rule goes into effect and is applied across the board to other parts of the system.
Across the board,
right.
That's the point.
Right. It's not that they haven't said that. So I think we need to acknowledge that, and I think that will impact the people that aren't in Part D as well. If prices come down in terms of list prices, if there are people out there that are paying list prices, if you do see a decrease in that, I think that will accrue to people that are not enrolled in the program as well.
It's a mystery why they're not.
Yeah,
because
I'm not sure.
There is a very good support for the low-income component that gives auxiliary services, and there are the options usually of going to Part C, the Medicare Advantage. It would be helpful to have some senior counselors trying to work with people, because there still exists zero premium plans, which would provide some kind of protection that there needs to be, I think, more outreach for seniors who are not enrolled for some reason.
Right. And I think there's probably also a lot of seniors who don't understand that there's a late enrollment penalty. And so they think, well, I'm not taking any drugs right now, I don't need the benefit. And so they don't sign up. And then when they do need it and they're hit with that penalty, same for Part B, then they're like, ooh, well, it's so expensive, I can't afford. And so I think we need to better educate seniors probably as to everything they need to be doing when they turn 65.
That's a lot of stuff, right? Yeah, Matt, I wanted to give you one last chance to talk about navigability for one.
Yeah, I mean, one of our big goals is how we make this healthcare system more generally simpler for consumers, seniors, patients to navigate. It is a huge problem. Health insurance is an incredibly complex product. We need to think about ways that we can simplify it and give people better information, more choices, and really make decisions that are easier and simpler, and reduce the level of complexity. And I think that's an important goal for us all.
Well, I want to thank you all for your questions, and thank you, Tara, Matt, Gail, and Liz for being with us today.